Frank for the 50th anniversary of this outstanding meeting. So internal carotid artery dissection is a leading cause of neurological events in very young patients, especially aged less 45 years old, but of course not in the general population. The etiology is controversial, including genetic, environment and other risk factors, and can be spontaneous, post-traumatic or associated to aortic dissection. The presentation is variable from segmental stenosis, occlusion or dissecting aneurysms, and these features can also be simultaneous. The natural history include asymptomatic patient in most cases, or patient presenting local or general symptoms, and usually these symptoms have a prodromal in about 80% of cases. But when we look at the management of this disease, we have no clear indication from recent Vascular Society guidelines. So we need to look to stroke association that are able to provide very low or no clear recommendation. What we know for this disease, maybe looking a bit more on the past, is that antiplatelet or anticoagulants are indicated in all patients, independently if they are symptomatic or asymptomatic. And that's why, in this way, we are able to lower the risk of recurrent neurological events. However, as the CADIS trial demonstrated, there's no clear indication if we have to go to antiplatelets or anticoagulants. And that's why the fate of the internal carotid artery dissection is really variable, ranging from recanalization, that is the most occurrence, or occlusion, that is the most persistent, or it's aneurysm formation, that in general is benign until compression symptoms develop. So when we have to think about surgery or endovascular treatment, when we have recurrence of neurological deficit, hemodynamic ischemia, contraindication of best medical treatment, aneurysm expansion, or contralateral carotid occlusion. But when we look at the type of treatment, also a recent Cochrane review was not able to find any evidence in this area of research, so we have to look to observational studies that indicate the endovascular approach as a first-line option. But also the endovascular approach has many disadvantages, including technical failure, thrombotic complication, reperfusion injury, but most of these can be overcome using a proximal embolic protection device, especially in terms of embolization, dissection extension, and wall rupture. And that's why, because as we can see in this explicative case, wires cross the lesion, I mean the dissection, only after we had endoclamped the proximal and the distal common carotid and external carotid artery. In this way, we reduce the potential of distal embolization and dissection extension. And also we are able to put some cover stent if we do arterial wall rupture. So in conclusion, ICAD should be suspected in young patients presenting neurological symptoms. BMT include antithrombotic regimen as first-line approach in both symptomatic and asymptomatic. We are not able to find difference between anticoagulants or antiplatelet, and the indication of operative management are limited, mainly secondary to symptoms recurrence despite BMT. Endovascular is preferred over conventional surgery, and proximal embolic protection device present potential advantages by reducing manipulation before clamping. Of course, we need larger scale study to determine ICAD natural history and develop, hopefully, in the future guidelines, consensus for treatment strategy. Thank you for your attention.